Take the mic, we are not able.
You are not able to hear.
Yes.
I will stand here.
Mic.
You want to record it?
Yes, ma'am.
I can't walk around with the mic slowly. I won't walk around. So patient chief complaint is forwarding grades upper friendly treatment. Prenatal history, patient has a history of prenatal jaundice. What can you infer from that? What is like if the patient has prenatal jaundice, neonatal jaundice, what can be the possible issues? Do you think if the patient has a neonatal jaundice, will it have an effect on the development of jaws? So if the patient has neonatal jaundice, he may have Gilbert syndrome in the future, maybe in his adulthood, maybe in the adolescent or adulthood, he may have Gilbert syndrome. What is Gilbert syndrome is, there may be stains, yellow stains in the teeth, and there will be hindrance in the jaw development. Okay, so this is a indication for us. Then you go to habits history. When you ask for habits history, the patient has a history of thumb sucking for 5 years and lip biting for 8 years. What does it has? What is the implication from this? So till what age is thumb sucking normal?
4 years.
4 years or 5 years before the permanent dentition develops is considered to be normal. So your escape from this situation. The patient doesn't have anything habits related malabsorption. Then you ask for familial malabsorption, right? Familial malabsorption, his mother is here and father also doesn't have any similar type of malabsorption. So you can come to one conclusion like one finding that the parents' genetic influence may not be there. Okay? Then you go to clinical examination. When you see the patient, what is the build of the patient? Average. Mesomorphic. What is the head shape of the head? Mesocephalic, right? Mesocephalic. Face, mesoprosophic face. Then extraoral examination. Extraoral examination you have to do in 3 places: anteroposterior, transverse and vertical. In anteroposterior, what are the things you will see for extraoral examination? First, profile, patient profile. The profile of this patient is convex profile. Divergence?
Anterior.
Posterior divergence.
Huh?
Anterior.
Why there is a doubt of anterior divergence? Chin prominence is there. Lower lip projection is there, but chin prominence is not there, right?
Posterior divergence.
So, divergence you will check the inclination of the forehead to the inclination of the chin. Chin, there is deficient chin. So it is
Posterior.
posterior divergence. Next is FMA, clinical FMA. Clinical FMA.
Average.
Behind.
Average, right? Then vertical. We'll come to vertical assessment. What are the things you check in vertical assessment? Rule of 3. So when you check for rule of 3, it's upper, middle and lower 1/3. Lower 1/3 is little bit increased when compared to the middle and the
Upper one.
upper 1/3. What can be the reason for this? When you see the patient. What can be the reason for that? Molar prominence? lip length at philtrum and lip length at corner of mouth. Lip length at philtrum is from subnasal to the dry border of the vermilion.
Vermilion.
Then at the corner of mouth is, you will draw a tangent from the end of the nose and you will measure it from the
Commission.
Commission.
corner of the mouth. So you will measure for upper lip length. Does the patient has anything related to that? Is it considered or normal?
No, ma'am. Not equal to the height of the
You
brain.
have to measure with scale. If there is a smaller group, I can ask you people to measure it too. Okay, it is average. Fine. Then insides are display. Insides are display at rest and insides are display at smile. You have to measure for insides are display at rest and insides are display at smile. Then transverse. So we have finished with anteroposterior and vertical. Now we'll go for transverse. So what are the things you will check in transverse?
Lateral fifths.
Facial symmetry. Symmetry, right?
Yes,
You
ma'am.
said symmetry. Facial symmetry. So the patient is, does he have any asymmetry? Apparently symmetrical. Safer one. Apparently symmetrical. Right? The patient has a apparently symmetrical face. His chin or it is not like obvious asymmetry is seen in this patient. Then rule of, in transverse you will see rule of
Fifths.
5. In rule of 5,
Chin is
This
placed. Chin
Not
is
symmetrical.
middle third.
middle third.
Middle fifths.
Middle fifth is reduced,
Yes,
right? This width of the mouth is lesser than the
Width of the nose.
interpupillary line. So what are the things you will see in rule of 5? You will draw a mid-sagittal line, you will draw a inner canthal line, you will draw a interpupillary line and a outer canthal line. Your inner interpupillary line should be equal to the corner of the mouth, width of the mouth, right? Intercanthal line is
Nose for
For the
width of the nose.
Width of the
So
nose.
interpupillary line is not
Same.
equal to the corner of the mouth. Then you will come to soft tissue. Soft tissue, what are the things you will see? So what are the things we saw now? You have to write your case history, right? Write the case history and submit, read it from before the exam. So what are the things we saw? First, demographic data, chief complaint, then medical history, dental history and familial history, then habits, history of habits, then chief complaint, extraoral examination. In extraoral examination, we
Vertical.
assess in 3 plates, anteroposterior, vertical and
transverse.
transverse. In anteroposterior, you know what are the things you have to see. In transverse and vertical. Rule of 3 and rule of 5 we will include in the transverse and
Vertical.
vertical. Now soft tissue. Soft
Mental.
tissue.
muscle activity.
Muscle.
Perioral muscle activity.
Perioral muscle activity. How will you check perioral muscle activity?
Palpation.
Check
All
for
the
the
muscles
lip,
of
whether the
muscles.
lip is
Competence
See for
of lip.
lip competency. Patient has
incompetent
Incompetent.
lips.
incompetent lips. Forehead.
Not
Straight forehead or sloping forehead.
Straight.
low.
Straight forehead. Next lip step.
Lip step. Negative lip step.
Right? Then nasolateral angle.
Acute.
Acute nasolateral angle. Retrolateral sulcus.
Acute.
A deep yeah.
Will a deep on deep.
Okay. Then after soft tissue you will go for smile. Right? In smile, what are the things you will check? Smile posture. Whether he has an optimal lip line.
8 components of smile.
Incompetency is there, optimal lip line is there, but the
It-
curvature of your upper lip.
Upper lip.
How is the curvature of your upper lip?
Non-consonant.
Non-consonant.
or consonant?
Non-consonant.
Non-consonant.
When will you say consonant and when will you say non-consonant?
It's not following a
Not following
consonant.
this my contour of the teeth. ma'am.
Is it not coinciding? Huh? Is it not coinciding? Huh? Increase in this correct as over the follow up that's my line. Yeah, correct as follow up upper is because it is aligned properly. So it is following the lower lip. I think it is consonant. தானே? சொல்லிட்டு நல்லா தெரியும். So patient கூட பார்த்து
இல்ல மேம் ஃபாலோ பண்ணல.
ஃபாலோ பண்ணலையா?
இல்ல ஃப்ளாட்டா இருக்கு அது ஃபுல்லா.
Smiler is not an arc, it is a flat. It is not a properly captured space. Okay, then after smiler,
Buccal negative space.
buccal negative space, lateral negative space. So lateral negative space is
Absent.
Absent.
Smile symmetry.
smile symmetry.
Asymmetrical.
Symmetrical.
Asymmetric. Gingival compound.
You have everything in the thing. I am saying referring and you are saying all the things. You are third year or second year?
First year.
First year.
First year. You are in touch with the cases.
They're presenting cases.
Gingival shape and zenith. Okay? Golden proportions. What is golden proportion? Photo is not clear. We should have made the PPT. Golden proportion. Altered or okay? Fine.
Okay.
Altered.
Okay.
Altered.
It's not smiling properly to understand, but actually, if you
Smile is only asymmetric.
can't is there, no? If you smile properly, you will get
என்னமோ ஓகே பரவாயில்ல வச்சுக்கோ அப்படின்ற மாதிரி. So golden proportion is no colors. Huh? Golden proportion is normal, right? Then
Bendel-
we come to
bendel
functional. Something I left. What?
Functional occlusion. Cant is present.
Okay.
We can see in smile analysis.
Smile analysis. Okay.
Whether
Cant is
occlusal-
present.
No, ma'am.
No cant is present. Then functional. Functional examination. So what are the things you see from functional? We can do functional examination. You want to volunteer? We'll do functional examination. Say what are the things we will check, we will discuss, then we will do functional examination. So what are the things you will check?
Postural rest position.
Postural
Rest
rest position.
position.
How do you bring the patient to postural rest position?
tap the chin.
So what are the methods?
Command method,
Command,
non-command method,
phonetic.
phonetic
It's
method.
just brushing up for the third years. Okay? Phonetic,
Command method.
command method, non-command method, and
Mix up.
combined method.
Combined.
Right? So what is phonetic method?
Mississippi.
We ask the patient to say certain words and
Consonants like M or S.
Yes. So the patient comes to a rest position after finishing the words. You will assess the, you will measure for. So how can you measure?
3 methods.
3 methods. Direct,
indirect,
extraoral, extraoral, intraoral, and indirect.
so what is extraoral?
and
Marking to
points and measuring it.
Indirect extraoral.
cephalometrics and kinesiography.
So cephalometrics you have to take in rest position and occlusion. It will measure. We'll try to measure. Or simply what we will do during our functional case, we'll do measure
Indirect.
direct extraoral method. So how will you measure for direct extraoral? You mark the tip of the nose and
The tip.
Chin.
Chin.
and you will measure at rest and
At occlusion.
at occlusion. So you will measure the vertical dimension. So that gives your
Previous
space.
space.
Fine. Then path of closure. How do you check for path of closure?
three types: forward, backward, lateral path.
நீ சொல்கிறத விட இட் இஸ் கிளாஸ் 2 maloclusion without functional shift, class 2 maloclusion with functional shift. Without functional shift, how will be the path of closure? Upward and forward, it will be like a curve, right? Class 2 maloclusion with functional shift. Sorry, and posterior functional shift. How will be the path of closure? Upward, forward, and backward. Anterior shift. Forward. So which has a good prognosis.
Which functional?
Forward. So backward I mentioned you will ask
Able to get it
direct the
forward.
forward. So it is posterior class 2 maloclusion with posterior functional
Functional
shift. Then you will check for this is in transfer AP dimension. In transverse dimension you will check for
Lateral.
lateral occlusion and
Lateral
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 narrative.
narrative. What is the difference between lateral occlusion and lateral narrative?
Skeletal and dental deviation.
In the opening of the mouth, midlines will be coinciding, but when they bring to occlusion, it will not be coinciding. That means the
Lateral.
patient has only dental component, not the skeletal component. Laterognathia is
Both skeletal
Both
and
skeletal and dental component.
so the patient has a
poor prognosis.
poor prognosis. So how will you make a conception by for which you will correct the midline and which you will not correct the midline?
Lateral occlusion will correct the midline. Occlusion only will correct the midline, no?
For laterognathia, you will correct the midline. Skeletal I divide. So you will give an acrylic split so that your thing changes. For dental correction, later on we will do. Remember like that. Okay? Then you will do TMJ and other functions. So what are the things you will check in TMJ?
Clicking, crepitus.
So this thing and all you know, right? So we'll do functional examination now. Who wants to come? I personally write Radhas.
See, this is not your exams.
It is just a discussion, right?
Just where you can explore things out. That's it.
Because I am from Radhas, UP, BG, everything Radhas.
I am from Meenakshi. No offense from other state people, just to make them informed. Someone want to volunteer and teach?
Ma, we are here to teach you or we are here to guide you only. Come. Because functional examination only, external examiner will go. Catch up.
First year is third years. How many of you have done function of brain space?
Come, we'll do examination. It's a hands-on, right? Come. Or everybody come. Everybody come.
They
Yeah, we both are.
transversely they extend that position.
English like this you will say.
H to
How do you
H,
write it in the case sheet?
H to H molar relationship.
First is skeletal.
Case sheet wise.
Skeletal and start from.
Soft gingival components will
அது விட்டுரு சாஃப்ட் டிஷ்யூ நம்மளுக்கு we know gingiva this pink
Shape
color
of,
stippling that and all leave it.
shape of the
Angles,
arches. Shape of the arches.
shape of the
Symmetry of the arches.
arch. Axillary arch, mandibular arch. Symmetry of the arch.
Ovoid arches.
Ovoid arches.
Mandibular arch,
Ovoid.
Ovoid.
U shape. U shape.
முன்னாடி கொஞ்சம் ஓவடா இருக்கு அது ப்ரோ இதனால கொஞ்சம் ஓட இல்லை சமி கொஞ்சம் ஓட இல்லை
Then, say me the positive findings alone.
end-on relation on both sides.
Molar relation, end on
End-on,
both
both
sides.
sides.
But when you see the patient, it is class 2. Just now I saw. So, maybe
Bite is wrong.
Bite is
picture.
wrong.
Bite is
Picture. Picture is wrong. Class 2 canine.
Class to canine relation.
Class 2 canine relationship.
Class 2 incisor.
First,
Premolar.
arco-posterior. Molar relation, canine relation, incisor relation. Then, vertical. Vertical is overbite.
Okay.
Overbite is
3 mm.
3 mm overbite.
Yeah, 3 mm.
Then,
Increased over Z.
increased overjet. Then transverse. Midline shift is there. Upper midline or lower midline?
Lower midline.
Lower midline to the left by 2 mm.
Lower midline by 2 mm.
Lower is shifted.
Yes.
To the left.
To the left,
To left
ma'am.
by 2 mm.
2 mm.
Okay, these are intraoral. Then saprophysics.
We are very better things.
I would suggest you people to take all the cephalometric readings. So what are the cephalometric readings you have to take?
Cleaners. Reading.
That only I am saying. You need not take all the
Saddle angle.
cephalometric reading. You have to follow
SNA. SNB.
Interincisor angle.
A and B.
incisor to NA is for what? Already you are saying upper incisor to SM, right?
Ma'am, position of upper central to the cranial base.
And
SM.
saddle angle.
Saddle angle, gonial angle,
Gonial
sum of
angle.
all the angles.
So when you see Petrovic, these are given analysis of facial
Facial.
skeleton, analysis of jaw bases, analysis of dentoalveolar structures. So it will be nice if you do in this format because taking all the readings, Wheeler, McNamara, Reed, George, Ricketson,
Old way.
for that
Old
itself
way.
5 to 6 pages will go off. And you will drop everything before the examiner. 1 page will fill like fall.
That's for exam.
Okay, now.
நிறுத்தி அக்கா எக்ஸாம் நம்ம எடுக்க மாட்டோமா இதெல்லாம் பிகாஸ் நம்ம சீனியர்ஸ்லாம் போடச்சு எல்லாம் போட்டோம்
So it will be nice if you do like this. Okay, analysis of facial skeleton, saddle angle. Based on the set they gave, it is set average condylar position. And articular angle is average position of condyle in the glenoid fossa. Then gonial angle was also average. Then when you see the Jaraback for this patient, it is horizontal growth pattern. Average or more towards the horizontal type. Then we will go for analysis of jaw bases, SNA and SNB. SNA shows orthographic maxilla and SNB is 76-degree retrographic pattern. Okay. Basal brain angle is horizontal growth pattern.
Keep it a clue.
Yes, sir. Don't break it.
Inclination
Yeah,
angle.
yeah,
J angle is anti-inclination of the palatal plane. Then you will do for swatch analysis. Based on the swatch analysis, it was seen that your mandibular base was 9.8 mm shorter than the maxillary base. So, upper incisor to SM was
Tell him it's class
110 degree and IMPA was 102 degree. So based on this, class 2
is needed for an exam and what had to be done for your functional appliance examination point of view was very well explained by Dr. Vidya, thanks to her. And now we'll next move to the part where we'll have to decide what kind of functional appliance have to be given. Okay. Yesterday it was a very wonderful lecture by Ratna ma'am, and it was almost everything was covered there. You people had 2 days of extensive functional appliance program, which we didn't have during our PG times. I did my UG from Meenakshi Amma Dental College and then my PG from MCOTS Mangalore, Manipal University. And I've been working associated in academics for the past 12 years, currently work as a professor and at Sri Venkateshwara Dental College, me and Dr. Vidya are both colleagues. So now we have come to a point where we'll have to assess what sort of functional appliance is needed. Now you all agree that this patient needs a functional appliance?
Yes.
Okay, what are the positive points?
horizontal drawer,
So horizontal duet, very good.
class 2 molecule,
Class 2 malocclusion, deep bite is
Deep-bite.
there. A functional retrusion is there, which is more important for you to give a functional appliance. And next point, we have to determine a functional examination. Functional examination is done already. Okay. So next we'll have to conclude which appliance we'll have to give. Okay. Lots of appliance which is being there, and this patient is in a late extension phase. Sorry, early permanent dentition. So almost all teachers are in permanent dentition. And the only thing is like we'll have to advance the mandible. First thing we'll have to decide what appliance we'll have to give. Depends upon the stage at which the patient is in. Okay. The growth phase says that the cervical vertebrae maturation is in phase 2. CS2. CS2. Okay. CS2 is pre-pubertal growth phase. But which is the ideal?
C3.
CS3 is ideal. Then we have a lot of time to give the functional appliance, but generally if you see, this patient is very ideal for a functional appliance. So which all appliance you know of?
Bionator. Twin block.
Can tell me this?
Bionator. Twin block.
Bionator,
Twin block.
twin block. Yes,
Frankel.
Frank.
activator,
Next.
activator, we can eliminate violet,
You can eliminate an activator.
we can eliminate violet,
We'll eliminate both. We'll just do twin block.
Okay, rest of the is an artificial fixed function, of course you can give. But right now, since this is a demonstration for a removed function of X, we'll stick to this. Okay, now we'll have to rule out which all appliance is not needed. Okay, anyways in exam, twin block is one universal appliance. Twin block is one universal, but when you go for consultation practice also, the maximum appliance which we give is twin block. Because from the patient aspect and also from the doctor's aspect, twin block is much easier. Okay, so we'll rule out which all appliance is not needed for this particular patient.
Activator.
I'll go
First
with
we'll rule out this
Frankel.
Frankel. Okay, not because of the difficulty in construction. Okay, that is exclusively for your clinical practice, but for the academic reasons also, Frankel cannot be given. Why?
Doesn't fit
What are
in.
positive things you look for in Frankel? If you want to give a Frankel, which appliance or which clinical finding will suit Frankel?
perioral muscle activity, surrounding muscle activity,
Surrounding muscle activity. If there is a severe constriction, a very V-shaped arch is there, can go for a Frankel. And then a severe lip trap,
Lip trap
with
or-
hyperactive mentalis, again you can go for a Frankel. And most importantly, it is given in a mixed dentition case. Okay, mostly a Frankel is given in a mixed dentition case, probably of a patient around 7 to 9 years of age. Okay, but Frankel is an excellent appliance. You can train the muscles very brilliantly. Here there is not much of muscle involvement except for the lower lip which is turned, and if you observe keenly there is a lower lip which is everted also, it is thick. What is the reason for the lower lip being thick? What habit he has?
Thumb.
Thumb sucking, he had
Lip biting.
Yes, lip biting habit. So any person or anybody who has a lip biting habit of a lower, there is a thick lip which is actually going to mask the actual appearance of the lip. Probably he would have had a thinner lip if he had not had that lip biting habit. Okay, the lip thickness is exaggerated because of the lower lip biting habit. Okay, so now I am not going to give frank and fine. Next,
Activator.
why do you want to look activated?
Bulky appliance.
Bulky appliance, okay, again,
Thumb sucking habit.
thumb sucking habit is there. Okay.
Cooperation won't be there by the patient.
Okay. Right. Again, activator is given in which?
Mixed dentition.
Again, activator. Both activator and bionator you are given mostly in the
That's my
mixed
logic.
case. Okay. So in that case, the ideal appliance which we arrive at is going to be a windblock. Okay. Now next question comes is whether you want to give a windblock alone or you want to give
Expansion is needed.
why expansion is needed.
Arch is constricted.
Arch is constricted, number one. With the cast, how do you check whether expansion is needed? So normally, in the normal occlusion, if you see, there is no prospect. But whatever you are going to do is, you are going to advance the mandible and check. Now, if you are going to advance the mandible forward, you have to check whether it is in a proper cusp to fossa relationship. Okay. If it's not there, means you will definitely need a expansion which is going to be done. Okay. So you can just check. I have given few tasks with you. You can just advance the mandible and check. Where are the presets? 1, 2. That's the third one. Just advance and check. You can actually observe a crossbite which is being developed on one side, which means that we have to expand the maxillary arch so that the mandibular arch fits into the maxillary arch properly. Your foot and shoe effect. Okay, so you expand the maxillary arch, the mandibular arch is going to get adapted to the expanded maxillary arch. Fine? And then what else modification we need for this appliance?
Habit.
If the patient has
Why do you want to give a lip counter? Lip trap will give a but
A habit
patient
breaking
has
appliance needs to be
habit-
given. Tongue.
habit breaking
if
appliance.
he has habit
He has-
history, continuous history.
He has a lip biting habit which is currently present. That again is because of the
Thickness
overjet
of the.
which is already there. There is a positive overjet. Overjet must be around, I don't have the clinical values here, but looking at the patient must be somewhere around 10 millimeters or so.
Twin block with labial box.
Twin block with labial bow. Okay, why labial bow?
It will prevent the overjet.
Very good. There is a proclination of the upper anteriors. So when you give the labial bow, there is going to be a headgear effect which is being exhibited by the labial bow, and this proclination is going to get pretty much
Reduced.
corrected. What about the lower incisors? Self-diagnose, you go through. I have explained it. Lower incisors over there. Lower incisors are proclaim. Ideally, whenever you give a functional appliance, your lower incisors will get more proclaim. Ideal case should be an upright lower incisor or even a retrocline lower
Retrocline.
incisor. But when the lower incisors are already proclaim, what kind of modification you want to give?
A label bow for the lower as well.
Give a label bow, or what else is there? Incisal capping, brilliant. You can give a lower incisal capping. Okay. Now I have got a recipe for the functional appliance. What all I should do? So means I need a expansion. Fine. I need a label bow, and then I have to do a incisal capping. So based on that, I am going to give a functional appliance, or I am going to take a bite register manifestation for that particular complaints. Okay. So before taking the bite, the first thing we check for is
VTO.
VTO. Okay, first we have to train the patient in a VTO. You ask him, do someone want to volunteer? Can come. I'll help you in translating.
Suganya. Just hold it like
So now we are going to ask the patient to take the mandible forward and ask the patient to bite in a forward position. I mean, on the knee, on the knee.
You want to come down and see.
Here, ma'am.
முதல்ல தெரியும்ல எல்லாரும் போயிட்டாங்க